Today we're going to be talking about the skeletal system. First, I would like to outline the main functions of the skeletal system and how they are performing the skeletal system, how it is performing those functions. So first and foremost, skeletal system is critical for support and protection of organs such as brain in the cranial cavity, spinal cord in the vertebral cavity, heart and lungs in the thoracic cavity behind the ribcage. It is essential for movement, since muscles that are attached to the bones contract and pull on the bones. Bones are essentially the levers for movements that muscles are involved in. Bones store minerals, first and foremost calcium and phosphorus, also potassium, magnesium and sodium. It is absolutely critical for hematopoiesis. A red bone marrow in the center of the bone essentially produces all blood cells. And in adults, bone also participates in energy storage. Medullary cavity of a bone in adults stores yellow bone marrow. Now, bones, each bone is an organ. So all bones together, your skeleton is essentially an organ system. Bone tissue itself is considered to be connective tissue, but your bones, not the bone tissue, your bones contain nerves, smooth muscles, epithelial tissues. It is very resistant to compression and even more resistant to tension. Bones are quite important for deriving various archaeological information because they can last much longer than flesh after a person dies. For instance, growth arrest lines allow scientists to find out when a bone of a particular skeleton stopped growing, and that will evidence that at this particular time the nutrients were scarce and were depleted, or owner was sick. So you can match the growth arrest lines with the historical data about famine or epidemic. Bones can be broadly classified into belonging to two different parts of the skeleton: axial skeleton and appendicular skeleton. Axial skeleton consists of the skull, thoracic cage, vertebral column, and sacrum. Appendicular skeleton includes pectoral and pelvic girdles, upper and lower limbs. Based on the shape, bones can be categorized into long, short, flat, and irregular. Long bones, such as femur or humerus, are longer than they are wide. Practically all bones of both limbs, except for carpal, tarsal bones, and patella, are long bones. Short bones, shown here and here, belong to, they are shaped kind of like a cube, can be found in wrists and ankles, and in the patella. Flat bones are thin, flat, sometimes curved. That will be sternum, ribs, and cranial bones, not facial bones, cranial bones. Irregular bones have usually complicated shapes. They do not fall into any specific category. Examples of irregular bones will be mandible, maxilla, ethmoid and sphenoid bones of the skull, all vertebrae, and coxal bones. The bone tissue consists of 4 major types of cells. First ones that we're going to talk about are osteogenic cells or osteoprogenitor cells. You can see them right here. These are stem cells. They can divide. They are mitotically active, what scientists say about this. They can be found on the surface of the bone in the layers of periosteum and endosteum, connective tissue that covers bone outside or inside. Osteogenic stem cells become more specialized. They differentiate into osteoblasts. Now, osteoblasts, shown here, do not divide, so they are mitotically inactive. They're found in the matrix of the bone, and their main function is to produce a mineralized bone matrix, proteinaceous compound called osteoid that contains large amounts of collagen fibers and also calcium binding proteins. Osteoblasts, further differentiate into osteocytes. That occurs when osteoblasts get trapped in matrix that they actually produced. When osteoblasts are trapped in matrix, they become osteocytes. So osteocytes are mature bone cells. They are mitotically inactive. They do not divide. They do not produce bone matrix, but rather maintain and monitor it. They also are critical in guiding bone remodeling, since osteocytes can respond to mechanical stimuli and guide other bone cells during the process of the remodeling of the bone. Now, you may have noticed that osteogenic cells, osteoblasts, and osteocytes represent somewhat of a same kin of bone cells. Osteoblasts are derived from osteogenic cells, and osteocytes are derived from osteoblasts. Unlike these 3 types, osteoclasts, which is another type of mitotically inactive, non-dividing cells, belong to a completely different cellular lineage. They are derived from macrophages. When macrophages fuse, they form these giant multinucleated cells that resorb the bone. You can see the surface of that cell in the so-called resorption bay. Osteoclasts destroy the bone during the process of bone remodeling, releasing calcium into the blood. So there are 2 types of bone tissue of sorts. The compact bone, the one that we're going to be talking about now, and trabecular or spongy bone. So compact bone, also known as lamellar bone, consists of osteons. This circle right here represents a single osteon. The longitudinal section of an osteon will be this. So this is a part of an osteon right here. It's a cylindrical structure. It's a cylinder, basically, that is parallel to the bone axis. It goes along the bone axis. Osteon consists of multiple concentric hollow tubes called lamellae. This and these are lamellae, concentric lamellae, and in the center of the osteon is a central canal that contains blood vessels, lymphatic vessels, and nerves. Interesting feature of lamellae is that in 2 adjacent lamellae, let's say in this one and this one, collagen fibers are directed into different directions. They are directed at an angle. So that angular relationship of collagen fibers' directionality into adjacent lamellae makes osteons especially resistant to twisting forces, therefore making a bone especially resistant to twisting forces. As I mentioned before, central canal that goes through the center of the osteum contains blood vessels, lymphatic vessels, and nerves. Central canals, in turn, are connected in some kind of a network by perforating canals, shown here. These perforating canals provide a connection for blood vessels between periosteum, the outer layer that covers the bone, and medullary cavity, the cavity right here, in the center of the bone, and central canal itself. Now, between lamellae are lacunae. You can see lacunae here, here, here. Lacunae are essentially cavities. Inside of those cavities are osteocytes. Osteocytes do not exist in the isolated environment. They are connected to each other by these tiny little projections that you can see on the picture. Those projections are called canaliculi. Now, when bone gets remodeled, basically bone gets destroyed and built again, remnants of the old lamellae form what is called interstitial lamellae. You can see them, for instance, here. Now, the bone itself is surrounded by circumferential lamellae. Here you can see a couple of circumferential lamellae that surround the entire bone. Next topic is spongy bone. So, spongy bone consists of multiple rods and forming lattice of sorts. Each rod like that is called trabeculae. This is why it's also called trabecular bone. And trabeculae are developing along the lines of mechanical stress, which kind of explains the structural strength of bones themselves. Interesting feature in the difference of compact bone compared to the spongy bone is that while in compact bone you do have osteons, in spongy bone there are none. No osteons, no central canal. They still contain, they still have lamellae right here. You can see lamellae, lacunae with osteocytes in them. Osteocytes are connected by canaliculi, so you can see all of that, little canaliculi here and there. Osteoclasts and osteoblasts on the outside layer of endosteum. But you can see that there are no central canals. You may ask how this type of bone receives oxygen and nutrients. Well, here the red stuff is the bone marrow, and bone marrow is perforated by multiple blood vessels, and these blood vessels actually carry oxygen and nutrients to the spongy bone. Let's take a look at the gross anatomy, the macroscopic anatomy of short, flat, irregular, and long bones. So all short, flat, and irregular bones are structured as a sandwich. There's a plate of spongy bone encased between the two layers of a compact bone. Basically, compact bone is like a bread, and spongy bone is like a ham. Now, long bone is much more complex. So, first of all, on the outside, also a compact bone, but spongy bone and the long bone is only at the ends. so-called epiphysis. The diaphysis of a long bone, the central part, is empty. There's a medullary cavity there. So again, this part is epiphysis, epiphysis, that's diaphysis. Now, articular surfaces of the long bone, surfaces that articulate, form joints with other bones, they are covered by the articular cartilage, which is essentially a hyaline cartilage. So in the adults, since spongy bone is in the epiphysis at the ends, the long bone, the red bone marrow in adults is found here in the epiphysis of the long bones, as well as in the spongy bone of the flat, irregular, and short bones. In newborns, red bone marrow found also in the medullary cavity. Eventually, red bone marrow in the medullary cavity is replaced by what's called yellow bone marrow, essentially fat. Okay. Now on the outside, bone, whether it's a long, short, irregular, or flat, is covered with a pretty thick connective tissue membrane that is called periosteum. You can see periosteum right here. Periosteum is attached to the bone itself by so-called perforating fibers, or Sharpey's fibers. So the Sharpey's fibers secure periosteum to the bone. They contain many nerve fibers, many blood vessels, and sometimes as a result of overexertion, these fibers get damaged and periosteum separates. When this happens, that leads to a condition known as periostitis, inflammatory condition. Imagine that this is separated periosteum. There's going to be inflammation right there. Example of periostitis is shin splints. Now, all surfaces that are inside of the bone, whether it's long, short, flat, or irregular, are covered with a thin connective tissue called endosteum. For instance, trabeculae of the spongy bone are covered with endosteum. Inner surface of the medullary cavity right here is covered with endosteum. Now, how do bones develop? The process of bone development, or osteogenesis, is sometimes called ossification. Ossification specifically refers to the formation of bony skeleton. It starts relatively early, when fetus is about 2 months old, and bones grow postnatally after the birth until 18 to 21 year of age. Usually in women, bone growth stops earlier than in men, but it starts earlier than in men too. Now, growth stops in early adulthood, but bone remodeling, change of the bone, is a lifelong process. First process of ossification that we're going to be talking about is called endochondral ossification. During endochondral ossification, bone tissue replaces hyaline cartilage. Most bones in the human body are produced this way. Almost all bones, practically all bones below the thoracic cavity are produced this way. So hyaline cartilage essentially forms a model of the skeleton, sort of a cast of a skeleton, before these cartilaginous structures ossify and form actual, true bony skeleton. So how does this process occur? First, in the center of diaphysis, center of a shaft of a cartilage, forms a primary ossification center. Blood vessels start to infiltrate the perichondrium of the cartilage, essentially replacing perichondrium with periosteum. Chondroblasts are replaced with the bone cells, osteoblasts, and osteoblasts start to produce compact bone. In the meantime, arteries and veins get into the medullary cavity that is formed in the diaphysis and start to bring more cells towards the epiphysis where secondary ossification centers form. These secondary ossification centers lead to the formation of spongy bone in the epiphysis of the long bone, leaving articular cartilage and so-called growth plate. So, as you can see, diaphysis is ossified first, then epiphysis ossify, and the only cartilage that is left there is the articular hyaline cartilage and the growth plate. Another type of ossification is the intramembranous ossification. It starts in the connective tissue membrane. It forms the majority of the cranial bones and clavicles. So these connective tissue membranes get invaded by the osteoblasts, which form ossification center. Osteoblasts start to produce matrix, the osteoid, and when osteoid calcifies, osteoblasts that are trapped inside of the osteoid form osteocytes. Eventually, this tissue membrane, connective tissue membrane, is fully replaced by the trabecular bone, and finally the edges of the trabecular or spongy bone undergo remodeling, forming a compact bone, and red bone marrow fills the empty spaces in the inside of that spongy bone. So here we're going to say a few words about the longitudinal growth of the bone. This is a growth plate which can be divided into 5 zones. When growth plate essentially is responsible for the increasing length of the long bones. So here you have reserve, or the resting zone, where chondrocytes, remember growth plate contains hyaline cartilage. So chondrocytes, cells of the cartilage, they produce matrix and essentially push the ends of the bone away from the center. In the proliferative zone, chondrocytes divide and they continue to push epiphysis, the ends of the bone, away from diaphysis. In the hypertrophic zone here, chondrocytes become bigger, lacunae become bigger, they start to die, and that's where calcification starts. You can see that, the tissue becomes less dense, the cavities become bigger. In the calcification zone, essentially all chondrocytes die, and what you are left with is a layer of calcified cartilage matrix and a bunch of dead chondrocytes. Finally, in the ossification zone, calcified cartilage is eroded by osteoclasts, and osteoblasts deposit new bone, and spongy bone develops in this region. What I specifically want to highlight is that cartilage does not become a bone. Cartilage is replaced by a bone in this case. Epiphyseal plate closes in females around 18 years of age, in males around 21 years of age. That's when growth of people ceases. It's not universal. Some people stop growing earlier, some people stop growing later, but in general, this happens around that age. So since we have finished our conversation about longitudinal growth, let's talk a little bit about the remodeling of the bone, or so-called oppositional growth. Oppositional growth of the bone is the growth in width rather than in the length. Also, it is basically a part of the bone remodeling that happens all the way throughout the life. The principle is of this process is very simple. So you have osteoblasts and osteoclasts that form so-called a remodeling unit. Osteoclasts remove the bone on the endosteal surface from the inside, and osteoblasts deposit new matrix on the periosteal surface. So bone become thicker, stronger, but since it grows wide, it is not too heavy because the cavity kind of increases. The remodeling essentially requires calcium, and this is one of the most important conditions for the successful bone remodeling. Now, remodeling of the bone happens in response to a particular mechanical stress. For instance, bone projections can be found where muscles attach and pull on the bone. The bones are curved, where they are very much likely to buckle. So, for example, upper limb, leading upper limb, like in this example of this tennis player, her leading limb will have thicker and stronger bone. In people who are bedridden or people who do not exercise, the features are not as pronounced as in people who do. So what are three conditions for the bone remodeling? First, mechanical stress. It determines where remodeling occurs. Second, proper hormonal levels, which determine when remodeling occurs. And finally, calcium. Calcium is most important here. It will determine whether remodeling is going to occur. The problem is that calcium levels in the blood are always a priority. Now, how does hormonal levels and calcium levels interplay in terms of the maintenance of process of bone remodeling? So when calcium levels are normal, bone remodeling can occur. But if calcium levels go down, that leads to the production of parathyroid hormone. Parathyroid hormone essentially controls the levels of calcium in the blood. Now, parathyroid hormone stimulates osteoclasts. Osteoclasts resorb bone, and that bone resorption increases calcium. Okay, so essentially, let's go over it one more time. Let me remove all the ink on the slide, and we will try to do it again. So calcium levels go down. That leads to production of parathyroid hormone, which stimulates osteoclasts, which stimulate bone resorption, which increases calcium levels. So you can see if calcium levels are low in the blood, then parathyroid hormone will stimulate destruction of the bone rather than remodeling. Okay. Now let's talk about the fractures. So fracture is the broken bone. So what are the main types of fractures? Transverse fracture. It's the fracture that is basically a perpendicular to the long axis of a long bone. Oblique fracture is the one that goes diagonally. Spiral fracture, very common among the professional athletes. The segments of the bone are pulled apart because of the twisting force. Comminuted fracture, like here, is common as older people, usually the bones are brittle, and that may lead to the formation of multiple small pieces of the bone. Impacted fracture, here you can see one fragment of a bone is driven into another. Green stick fracture is very common in children when only bone is only partially broken. In children, the bones are kind of softer, and it's pretty much like breaking a green fresh branch is much harder than to break a dry branch. Open and closed fracture. In open fracture, a bone fragment penetrates the skin, and in closed fracture, skin remains intact. Other fractures that are not illustrated here: displaced versus non-displaced. In non-displaced fracture, bones do not remove from their normal position, and in displaced, they do. Complete and incomplete. So basically, green stick fracture is an example of incomplete, and here in this illustration, oblique fracture is the complete breakage of the bone. In children and middle-aged adults, it's usually the result of trauma. In old age, main reason for formation of a fracture is the loss of the bone, osteoporosis. Treatments of the fracture requires reduction or realignment of the broken ends and immobilization. Closed reduction is when a doctor can manipulate bone ends into the correct position without a surgery. Open reduction is when surgeon secures the ends of the broken pieces using pins or wires. Let's talk a little bit about bone pathologies of different sorts. First is osteomalacia or rickets. Osteomalacia refers to the condition in adults. Rickets refers to basically the same condition as in children. Here you can see illustrations of children with osteomalacia. The reasons are deficiency of vitamin D, hypocalcemia due to hormonal abnormalities, or insufficient calcium in the diet. That leads to poor mineralization of the bones. Bones become soft and weak, which leads to bowing of the legs and other deformities of other skeletal bones. Paget's disease, and here you can show Paget's disease on this X-ray, is the disease of unknown cause, genetic, hereditary condition, potential environmental condition. Bone deposition and resorption become excessive and haphazard. It leads to the formation of high ratio of spongy bone, comparative to compact, reduced mineralization of the bone, and generally these bones are more prone to fracture. Risk factors for Paget's disease is being a male, being older male, and being of a particular national descent. One of the most common conditions associated pathologies of the bone is osteoporosis. In this condition, the resorption of the bone goes faster than the deposition. The main cause of osteoporosis currently is the lower levels of estrogen in females after the menopause. In males, testosterone levels also decline with age, but not as fast as in females. This is why being a female is one of the significant risk factors. Osteoporosis affects spongy bone of the spine and in the neck of a femur right here. Also may lead to comminuted fractures of the vertebrae and comminuted fractures of the hip. It affects mostly older people of a Caucasian descent, postmenopausal females that have petite body form. People who exercise rarely are at the higher risk. Other risk factors include insufficient protein in the diet, diabetes, smoking, hyperthyroidism. Interestingly enough, in males, androgen-suppressing drugs, which reduce the amount of testosterone in the blood, may also contribute to decreased bone mass and osteoporosis. Our last part will regard the anatomy of the skeletal system. As we mentioned before, there are 206 named bones in the skeleton, which can be divided into axial, which is lighter here, and appendicular skeleton. There are 4 main types: long, short, flat, and irregular bones. We reviewed them already. So I'm going to move on to the anatomy of the skull. So the skull bones can be divided into cranial bones. Let me choose different color. Cranial bones and facial bones. In cranial bones, up front is the frontal bone. There are 2 of them, 2 parietal bones that form kind of a top of the skull. In the back of the skull is a single occipital bone. 2 temporal bones form sides of the skull. Sphenoid bone is a beautifully shaped, actually, bone. You can kind of see its butterfly-shaped bone, together with ethmoid bone, which is barely seen here, this brown stuff. It's deep in the skull. You see the ethmoid bone. It forms mostly the bottom, the middle and anterior portion of the base for the brain, so-called middle and anterior cranial fossae. Now, facial bones include zygomatic. Here's the frontal view, so cheeks. Nasal bone, right here. Lacrimal bone, really small purple bone here, and you kind of can't see it here. Maxillary bone, it's upper jaw and mandible. This image you also see maxillary bone. It's basically 2 fused bones and a mandible. You can also see inferior nasal conchae, part of the wall of the nasal cavity, and you can see vomer. Now, vertebral column, shown here, as you may notice, has several curvatures, which allows it to work as a shock absorber overall for the body. Fibrocartilage that forms intervertebral discs is very resistant to vertical pressure, so it adds up to the ability of the vertebral column to absorb vertical tension. The curvatures make your vertebral column to work kind of like a spring, and it consists of 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, sacrum, which is 5 fused sacral vertebrae, and coccyx, which is a tailbone. Vertebral column also protects the spinal cord, which is encased in it. And here you can see how structure of the vertebrae reflects their function. So cervical vertebrae are relatively light. They have relatively small body, triangular vertebral foramen. They have bifid spinous processes, and they have transverse foramina, transverse foramina, are found only in a cervical vertebrae. Now, thoracic vertebrae, they have spinous process pointed down. The vertebral foramen is circular. The body of the vertebrae is more massive. There are no thoracic foramina, and articular processes are more prominent. Now, lastly, in case of lumbar vertebrae, they have the most massive body because they have to maintain the weight of the basically entire trunk. The spinous process right here is more blunt and more horizontally oriented, and vertebral foramen is triangular. Ribcage consists of 24 ribs organized in 12 pairs. There are true ribs and false ribs. First 7 are true ribs. They are also called vertebrosternal because they are attached to the sternum and to the vertebral column. Ribs 8 through 9 are false. They're called vertebracondyral because the heads are attached to the vertebral column. You can't really see them right there. And the ends are attached to the costal cartilage. Ribs 11 and 12 are false ribs that are called vertebral or floating ribs. Now, back ends, because this right here is considered to be a head of a rib. The ends of the ribs are attached to the sternum. Sternum itself consists of 3 parts: manubrium, the body of sternum, and xiphoid process. Interestingly enough, xiphoid process is the last bone in the human body that ossifies around the age of 40. Next, we're going to talk about appendicular skeleton. We're going to start with the pectoral girdle. Pectoral girdle, there are 2 of them on the right and the left side. Each pectoral girdle consists of a clavicle and a scapula. Its function is to brace upper limbs and attach them to the axial skeleton. The bones of the upper arm, is humerus, which articulates with the scapula and clavicle in the glenohumeral joint. Bones of the forearm are medial ulna and lateral radius, which on one end articulate with humerus forming elbow joint, and on another end articulate with the carpals, wrist bones, forming a wrist joint. Carpals articulate with metacarpals, 5 metacarpals, from 1, which is thumb, to 5th, which is pinky. They form a palm. And finally, 14 phalanges form fingers. Thumb has only 2 phalanges, while other digits have proximal, middle, and distal phalanges. Pelvic girdle consists of the sacrum and pelvic bone. Coxal bones are less flexible. Well, generally, pelvic girdle is less flexible than the pectoral girdle. That should be pectoral. Now, each coxal bone consists of 3 distinct parts. You can see ilium, pubis in the center, and in the back, kind of can see it's called ischium. Now, male and female hips are different. You see that female hips are wider. They are, the pelvic brim is more oval and wider. They are shallower, and the pubic arch or pubic angle is usually obtuse, while in males, pubic angle is usually acute. Now, femur, the bone of the upper leg, largest and strongest and the longest human bone, articulates with the coxal bone at the acetabulum, forming a hip joint. At the distal end, femur articulates with tibia and patella. Patella is your kneecap, and tibia in the lower leg is the only weight-bearing bone. Tibia is medial, while fibula is lateral. You may ask, what's the function of fibula then if it doesn't bear any weight? Fibula is necessary for the attachment of various muscles. On the distal end, both tibia and fibula articulate with the tarsals, the ankle bones, while tarsals articulate with metatarsals that form a sole of the foot, and metatarsals articulate with the digits, with the phalanges. Just as in the hand, phalanges, there are 4 phalanges in fingers 2, 3, 4, and 5, while in the big toe, there are only 2 phalanges, proximal and distal. Now, how do we classify joints? Let's talk a little bit about joints, about articulations. So, joint is a site where 2 or more bones meet each other. They enable movement. They are necessary for the flexibility of the skeleton, and they can be classified based on their function and based on their structure. So functional classification implies whether or not joints can move. Synarthrotic joints are non-movable. Amphiarthrotic example would be a sutures between the bones of the cranium. Amphiarthrotic joints are slightly movable. For example, pubic symphysis, the joint between 2 coxal bones. And diarthrotic joints are freely movable. Example would be, for instance, elbows or shoulders or hips. And anatomical structural classification of joints explains how bones are connected. Bones are connected by the fibrous connective tissue, collagen fibers. These are fibrous joints. Sutures in the cranium, syndesmosis, for example, tibial joint, distal joint in the ankle, and gymphosis, joints between the teeth and alveolar processes of the mandible or maxilla. Cartilaginous joints are characterized by the bone ends being connected by a cartilage, like synchondrosis. It's a joint, for instance, between the ribs and the sternum. Or symphysis. Fibrocartilage connects 2 coxal bones, the pubic parts of the coxal bones, and it's a slightly movable joint. Now, synovial joints are characterized by the capsule that is filled by the synovial fluid. Ends of the bones are covered with hyaline cartilage, and all synovial joints are freely movable. Examples would be hip, elbow, shoulder, or temporomandibular joint between the mandible and the temporal bones in the skull. So let's talk about the movements that joints can produce, talking of course about synovial joints. And we're going to start with a flexion and extension. So if you take a vertical axis, right, like this, you will see that in case of flexion, the angle between the limb and the axis decreases. In extension, the angle between the axis and the limb increases. So again, you have extension here. So you can see here flexion and extension of the knee, flexion and extension of the shoulder, flexion and extension the head. This is the flexion and extension of the dorsa of the vertebral column. Now this is abduction when it's a movement in the coronal plane when you remove either your upper or lower limbs away from the central vertical line. And adduction is when you add them, bring them back towards the central line. Circumduction is not the same as rotation. It's the movement when the shoulder doesn't really move and only the end of the limb, either arm or leg, makes the circle. Essentially, it is moving like in a cone fashion. Rotation, the head, you can rotate the trunk. Basically, rotation is the movement of the entire part around the vertical axis. You can rotate by the way you hip. You can rotate it laterally or medially. And finally, some special movements. So when you stick your arms forward and your palms are facing up, that's a supination. And when they're facing down, it's a pronation. When you elevate your feet up, but basically standing on your heels, that's dorsiflexion. When you stand on your toes, you're performing plantar flexion. When you walk on the inside of your feet, that's eversion. When you walk on the outside, that's inversion. So when you roll your ankle, for instance, to the outside, that's inversion. Finally, some very special movements. Apposition of a thumb, when you make kind of a sign of OK with your index finger and the thumb, or middle finger and the thumb, you know. Elevation and depression of mandible essentially is chewing. And this is the mandibular movements, retraction and protraction. You should know these movements for the exam.